Hello, everybody. Welcome back to Splints and Whiskey. This is the podcast where we get together with military medicine, lots of our heroes we have a conversation about medical simulation training for combats. We talk about way things used to be, the way that they are now, and then ways that we can improve as combats and conflict medicine kind of changes throughout conflicts changing. And we've seen a lot of that lately. My name is Liz, and I am really excited because I have a new friend on the podcast, and he is absolutely awesome. We met, yes, and he has his whiskey. Welcome to Splints and Whiskey. He has his whiskey. So um, this is my friend Sam Patrick, and I'm going to have Sam introduce himself. But we actually met kind of through in the medical training community. And I've already learned so much from Sam. And I'm really looking forward to today's conversation because we're going to talk about different techniques on how do you build a training scenario, especially in combat medicine, and then manage all of the things that you have to do. So Sam, thank you so much for being on today. And will you please introduce yourself to the listeners so that they know a little bit about you, and then we'll start our conversation.
Hey Liz, thanks. First of all, thanks for having me. Hello everybody out there. Can't follows me around awkwardly. I haven't figured out how to manage technology yet. So Sam Patrick, just retired off of 21 years of Army service, with all 21 of them being a medic. Spent 4 or 5 years, 4-ish years with one of the Stryker Brigade infantry combat teams. Did a nice 16, it was about 17 months total to the Middle East, most of it in Baghdad. Got my teeth cut there, then dropped an application to the 160th Special Operations Aviation Regiment, went over there for 12 years, did some things. Then last 4 years I spent in the National Guard working for the Washington State counter-drug program at the Western Regional Counter-Drug Training Center, where we basically took lessons learned from the DoD operational medicine environment and then taught cops and other first responders how to do it in the streets of America. So paying it forward. Actually, I think our best success story from that class, a buddy of mine in Tuckwell here in Washington, where I'm at, they 4 hours later after taking our class was on the road and saved a life with the skills they were given. So
That's
pretty
awesome.
pretty cool. I got to do lots of simulations. Yeah, so I've been in the medical training space for 15 plus years now, because I was a flight instructor at the 160th and became standardization instructor, so kind of running the whole training program. And then the last 4 years, obviously, taking the complex concepts in tactical combat casualty care and translating them into a place for the civil space.
That's
and
awesome.
Got 3 different paramedic certifications. I also currently work part-time at the Fort Lewis Medical Simulation Training Center. I'm also doing a bunch of private consulting. If you need some training, let me know.
Yeah.
Primarily, yes, I'm doing like high threat, civil-based medicine and kind of incident command, like disaster management, since my degree is in a disaster management background. So been teaching stuff for a long time, and I think you during the intro you brought it up, like one of the biggest challenges we have in the space is how do we replicate and export the crisis sites that we deal with when we're doing this stuff live.
Yeah.
So
I'll tell you, like, I'm so glad that thank you for your service. Congratulations on retiring.
thank you for your taxes.
You're welcome. Thank you for my freedom.
I don't know. I wasn't around in 1776. I'm just saying.
Oh, your resume was so good. I thought for sure you wrote the
I'm not
Constitution.
that old. Thanks. Liz.
You're welcome.
I got some gray in my beard, and I'm salty. I'm not that salty.
Awesome. Well, no, I'm glad that you brought this one up. I mean, you and I met via LinkedIn. Gosh, like the way that and someone connected us because your passion for training, and obviously because you're good at it. And he suggested, he wanted us to meet. And I think I'm so thankful for that, because in the little time I've known you, you have sent me pictures when you're in different scenarios, and every day it seems like something different, and it's also different. You're teaching different communities too,
Hmm.
even out of the country, abroad. I mean, so tell me a little bit about how you get in, how you plan and how you prepare for a simulation. I hear about this a lot in medical simulation in the space that I'm in when I'm inside of a hospital, right?
Right.
So much people teach you how to teach, right? For sim and hospital settings, but not what you guys do. You guys, whenever I go out in the actual field and I'm putting on, like I'm just wearing jeans and a ball cap and I'm going out in the field, it is an art and there's a lot to juggle. Plus, you're trying to meet the requirements, grade people, do all of that stuff as well. So please tell me a little bit about what goes into your planning. And then if you don't mind, I may interrupt and ask little questions as we go, just because I'm way into this stuff. I love it.
Yeah. Yeah. So, well, that's, you kind of hit the nail on the head. So much of it's planning, and honestly, it's it's a labor of love, between whoever's driving it, and not every trainer is created equal. And because if you're not willing to put the work in on the coordination on the front side, like if you're trying to do a big like multi-agency or a big unit like full spectrum thing, like it takes a lot of work, and really it comes down to one person. Like if you're not willing to be that glue, like for example, I'll look back at a training event I planned for the 160th. We would do a medical full mission profile every quarter or so, and so we planned this one where we went down to Oregon. We brought our simulator, our helicopter simulator down there, did a downed aircraft scenario. So we brought in elements of every company. So we had our both Chinook companies, the Blackhawk company, and the maintenance company, because we deployed the DART team. We had an ODA from First Group that we were working with. So the ground force we got reps working directly with ground force. They got reps working with us. I think they did fast rope and all that stuff to get in there. Then we had to reposition them to the crash site. They established security. We spin up our downed aircraft recovery team with some PJs. They go out, do the thing, and not ironically, well, like after we completed this training event, the PJs from Oregon, they're out of Portland, Oregon, deployed downrange and actually responded to an incident we had with one of our aircraft. Where unfortunately, CW3 Jake Sims perished in the crash, but they basically were able to take those lessons learned, apply them directly, and they already had the interoperability from working directly with us in a downed aircraft scenario in Oregon that was full spectrum. So like I haven't even talked about medical. Like there's no medical talking right there. Like that's all white cell, red team, like building the scenario, building a plausible scenario, and then taking it. And since it's a medical training situation, like we inject the casualties, and then the casualty simulation is the priority of the training, but you get all these parallel units getting additional training with it.
That's awesome.
So like that's like the problem with medicine, especially operational pre-hospital, like it doesn't happen in a bubble. Like hospital-based training is easy because people come there. Like you're not dealing with the scene, you're not dealing with people, you're not dealing like it's a known point on ground, bring sick people here, they do their things inside the hospital. So it's very much more controlled. When you're pre-hospital space or combat space or what field space, like so much of it goes into the operational management. Like if and you look at the military, when you like medical wants to emphasize the clinical, when you look at the other G shops or N shops or J shops, like J3, J4, the operations and logistics people, they focus on the movement, the plan. Like you look at the combat training center rotations for the Army, like what they focus on is not so much the clinical treatment as what is your medevac plan, because they care about clearing the battlefield of, for lack of a better term, the personnel. The human beings are the equipment. If the equipment gets broken, how do we move that to the next level of care so the combatant, the maneuver commanders can continue to warfight?
Right.
I think that is the art of recognizing on medicines, like especially military medicine, like our job is multifactorial. Like yes, it's provide world-class care to soldiers, but also it's to rapidly move to evac as quick as possible our injured warfighter, because that will allow the commander to regain their mobility and maneuver.
Right.
So building those scenarios out, if you don't factor in everything, you're going to get finger drilling, pixie dusting, and you're not going to have the tyranny of time and resources that actually happens. Like working at the medical simulation training, like, okay, you got 20 minutes till medevac gets here. It's like, okay, like you're doing simulations on these fixed timelines where you can like inject random stuff here and there, but like since it's a standards based assessment, you don't have a lot of that flexibility. So like that's another rub with the simulation space, is if you're doing standard based assessment where everybody needs to go through in the same manner, you lose a lot of the creativity. And also, while they may be getting the clinical training, they're not particularly getting like the full operational picture. And as an instructor, like having, like, it's honestly like, when I think about a good medical simulation, is like to do the full spectrum, like that FMP is like, I need people proctoring casualties, I need other OCTs, observer controller trainers, basically managing the operational leadership aspect. I need other people playing the red cell, which is injecting the contingencies that they have to deal with. You can have a single person do it all, but they need to be highly neurodivergent and ADHD to rapidly shift attention. To include like communications, like how many different radios do you need to talk to? How are you communicating? Like, so the actual medical treatment, throw an arbitrary number at this, 25%. Because if I don't have a 25% good the other 25% comms, the other 25% mobility, and the other 25% is command and control. Like if those other elements are not practiced, drilled, and trained, like you're gonna have flawed medical treatment because you're delaying things.
Yeah, your outcomes are going to be so much worse if you're not training on the like the comms and things, or things that if your equipment breaks, or if you're, just any little hiccup that comes with it that you've actually yourself seen when you were a warfighter, and when you saw this real stuff in the field, when things don't always work perfectly, then you have to plan for that. You got to train for that, because muscle memory is only as good as if you're not practicing on all the aspects of the care, that, like you said, I mean, you could be the best medic in the world, but if you don't know how to be nimble in a situation to be able to get the patient out of there in time, and think on your feet like that, you got to train for that, because we train like we fight. Yeah.
Well, and that's the big thing that drives me nuts when I observe other people's trainings. They say, well, I would do this. I'm like, do you have it or not? If you don't have it, figure out what you're going to do. Like, there's none of this, like, if I would have, like, no, well, okay, and that's, I think, one of the disservices we do, is we allow the pixie dusting, for lack of a better term. Like, okay, I would give them blood. I'm like, okay, where's your blood? Like, did you start a walking blood bank? Do you have blood supply? Well, we would. I'm like, okay, what if you're 2 weeks into a full out brand new conflict, you're black on supplies, what are you doing? Like, getting them to actually think in that mindset of, okay, you have what you have in front of you. If I like the dummies, or we use the layered old 3G sim people at the Mystic, which it's a good, like, I personally think it's a much better hospital based training system, because it does give a lot of good feedback. Right. But like when they take a pulse, I'm like, they look up at me, I'm like, no, it's giving you a pulse, take it. Or like they put a pulse oximeter or another medical monitor, electronic monitoring. They don't get a reading. I'm like, you got what you got. Like, it's reading nothing. And I think that's focusing like recaging towards actual medical simulations. Like, I find personally, when I think of like the best gold standard, I'll throw a shout out to a company, Casual Resources in the UK. They're a phenomenal clearinghouse for medical simulation role players.
Cool.
So most of them are former British Ministry of Defense who've been
What's it
injured
called?
in the casualty resources.
Casualty resources. Thank you.
Yeah, great company. There's a couple of companies in the U.S. that do similar, but these guys are by far the best I've ever worked with because they bring in world-class makeup artists. Most of the role players were military. Most of them like have been injured in combat. Like they have a lot of amputees. So having a good role player that's been through it does it a lot. I can get actual biofeedback. I can put a monitor on, get readings. I can move the person like they're a person. That's another one. Like none of our dummies or simulations move like humans. They move like rubber.
Yeah.
And they don't bend the same way. They don't talk. Or again, a trauma mannequin. A mannequin works as well as the operator who puts in the effort to run it. And I've learned that managing a simulator, like a Trauma FX sim or a Laerdal, like it's incredibly resource intensive for bandwidth. So like you're there trying to manipulate controls. It's not always the easiest interface to manipulate. It's not fast enough to give changes that you need. So you're spaced down in some tablet or controller, trying to change when I can't watch a medic. So like now you're adding layers of resources that to run a good simulation, I need someone to proctor and run the mannequin, and I need someone to watch the medic or watch what's going on because like I do it time and time again. Like I'll be face down trying to like get something to bleed or not bleed. And I'm like, all right, I have no clue what they're doing. So, but with a human role player, like now I can ask them, hey, did they do this? Or how did that feel? Like hypothermia, they can get a little bit more appreciation for that. And then too, like, but then you're like, oh, I can't do procedures to this human. I'm like, all right, yeah, valid. I can inject partial task trainers. I can inject live tissue potentially. I could inject cadaveric tissue, perfuse cadaveric for the actual procedures and bounce back and forth.
I want to ask you about that. Sorry to interrupt or stop you there. I want to ask you about that. When I first started selling to the military, I sold Laerdal to the DoD. And I remember when the Mystics got them, and then sold my trauma mannequin of choice. I can't help it. Is the Tomakin. I love the Tomakin. I think Trauma FX is good too, but I love the Tomakin. So, but I sold those two, and it would always surprise me that we didn't have as many trauma mannequins out in the field. I mean, I can't believe when I go to a command and there's a sim man, they're trying to pull a sim man outside. I'm like, okay, guys, like sim man is killer for the MTF. Let's get some, come on, we need to get with the program here. But anyway, there was this phase for lots of years where everybody on the selling side, like on my side, people, our MTFs and our commands and everything, they were buying their brains out on mannequins. It was like, they brought their ass off, like mannequins everywhere, right? And lately, when I'm out in the field, I'm like, okay, we are so freaking mannequin heavy right now. There's so many mannequins everywhere. And you've got operational issues all the time. We all know that we've got service issues. It's like Murphy's Law. You're getting ready to run a sim and something breaks or gets clogged or whatever. So that happens, right? But then B, what I've heard and what I've seen is like with prolonged field care, especially now, there's not the feedback, right? So now I've started saying to people, especially after we didn't have a budget last year, it's like, let's spend our money smart. Don't you think that we're cool on mannequins? Like we have enough mannequins right now. I'd like to see people incorporate more task trainers. You can buy more, and then you got wearables for your people, and then they know what it's like to be a patient, right? So tell me, okay, so you think that? Tell me some task trainers that you're like, I cannot live without this, or if you don't mind, or you don't have to name them, but however you want to do it. But I mean, certain things that you think are kind of staples that you like using that you could use with, especially to get feedback from people. Maybe.
I'm not gonna even name specific. Like to be honest, like the task trainers all, no offense to all your friends in industry, are all lacking. Like to be honest, like if I'm gonna do crikes, Like I would rather get pig tracheas from the butcher shop
Yeah.
and then put some skin over it, like, because then I'm at least feeling anatomy that's similar. It's gonna be, maybe it's not gonna be warm, but it's gonna not be. I don't need to lubricate something
Yeah.
to put a crike in someone, because if I'm training a 68 whiskey 10 level brand new medic and their primary airway is a crike, like, okay, this is how it's done on rubber, but this is what real tissue feels like. Even doing
That's
needle
awesome.
D's, go and get ribs, like real ribs, like
Yeah, that's cool.
and that's because I've kind of matured past like the procedure focused training is what I'll call it. It's like we hyper focus on teaching people these procedures. Then when they get to a situation where the algorithm kind of says we can do it, they're going to try to do it, as opposed to getting them to critically think. So like, yeah, if I like was to hit, I'll just from the military medicine pre-hospital perspective, like a bomb proof, just like spot on crike trainer that bleeds. I want a crike that has a thyroid artery or vein that goes across the cricothyroid membrane, so they can learn that, oh, if I'm going to do this, there may be problems.
Yeah, yeah.
Then plumbed IVR, like if an IV sim without like, and the problem with a lot of this stuff is it's a pain in the ass, pardon my French, to get to work as designed. And it really, like, you puncture it once, it's done. Like,
Right.
like a real IV trainer that gives real flash, hard sticks, that could be ultrasound like worthy, like that I could do peripheral IV ultrasound or maybe even deep access if I wanted to. And again, I'm just going to go basic medic stuff.
Yeah,
like,
that's what I like. That's what I mean. I'm so glad you
don't,
did that.
they don't get enough reps on IVs anymore because they're not
Right.
doing patient contacts on a battalion aid station. No one does like crike. Like the reason why we teach it is it's not, you know, it's not even close to risk free, but like it is significantly easier to maintain the tactile skills necessary than direct laryngoscopy. So needle, like a good decompression simulator,
Yeah.
that could do, like, that would respond to stimulus of burping the seal, that would respond to needling, that would respond to finger Thor, that would respond to putting a chest tube in. What else? And to be honest, like if we could get a sim that allowed us to put a monitor on and actually get the feedback that we were looking for, and that's one of the like training monitors. Like if like some of them are able to, like there are devices out there that I could control from my phone and give them the feedback. Like I want to change the 12 lead. I want it to do this.
Yeah, yeah.
And then it changes it on the machine. So they can get the habit of, okay, I have a change on my monitor, checking patient, proctor has to say, yes, your patient is symptomatic for what you're seeing on the monitor. And then they do some treatment. Because, yeah, the wearables are all right. Like the cut suits are all right. Like, actually, the casualty resource people, they do a phenomenal crike training. So they put the wearable crike trainer on the role player.
Oh, that's cool.
So they're actually criking. Like it sticks out a little bit, and it just basically looks like a big goiter. But like it allows them to crike them. They usually will have the role player will put a blood packet in their mouth, and then like as the medic rolls up, it gets like blood everywhere.
That's cool.
So like they have to do the recovery position, all this other stuff. Like it's the closest simulation I've ever seen to like what real things are. Because like if I'm criking someone, that's a crash airway. They don't have an airway if I need to crike them right then and there.
Right.
It's chaos, and like giving medics the ability to see how chaotic it is. That's the key. And it's a long answer to a really simple question, right?
No, it's not. I mean, this is awesome. This is awesome. That's exactly what I meant. Exactly what I meant was like, for the skills, like what is kind of the thing that I mean, it's great. If you're doing a sim, and sorry if I interrupted your answer. So did I?
I had another point, but I forgot it. I think TBS. TBS is real, man.
Sorry. backing it up really quick. So let's say that, so if you're running a scenario like at the Mystic, for example, if you're running a scenario, then how do you have enough instructors to do the things that you're talking about?
No.
So how many people manage a training?
So when you're running a lane, like just me, one person, you're responsible for managing the room. You're responsible for managing, like, getting the dummy to work. Like, half the time, the sim man that I was using yesterday wasn't connecting. So I'm like, all right, cool. Like, it's just hard. Like, I'm not gonna waste time on spending all my energy trying to get something to connect. If it's not working, that I'll do what I can to give the so I end up becoming the role player. Like, I'm giving them all the
Yeah.
feedback. I'm talking the whole time like I'm the patient. It's minorly exhausting as well when you do that 10 times in a row.
Right.
But like, yeah, that's my train of thought. Neat. Oh yeah, and the problem too is, like, as you have to be, like, the motivation level you need as an evaluator and instructor and a teacher is, like, astronomically high if you're going to maintain the same quality of simulation for multiple reps.
Right.
Like,
Yeah.
I look at the special operations medic refresher course. We do a trauma lane in the morning and a trauma lane in the afternoon because they're so like, the way they run them, they're pretty high, like, very high quality, but it's just so resource and bandwidth intensive on the instructor to give a good simulation that like, you can't just keep repping them, and, like, it
Yeah.
takes time to
How many
reset.
students are in one?
So we run, I think, for when we're running trauma lanes, like, we had a CLS class last week of like 20 people.
Okay.
So we
And
would
like the special operation one that you did morning and afternoon, how many are in
it's
that?
6 in a small group.
God,
Well,
man. Yeah, you got to be like, and you have to like be totally on it because you want to give the same amount of training to the first person than you do as the afternoon last person.
yep,
Yeah.
yep. And that's the thing is, like, it's hard. I'll be perfectly honest. I'll be transparent. It's like, it's hard to stay motivated as an instructor when you're. And to be honest, when I look at a CLS class, or like when I've run EFMB, the Expert Field Medical Badge, like, I pay attention to what people are doing during the train up, because, like, because that's my opportunity to kind of find the process, and then the skills validation checkout. Like, okay, like, can you follow the algorithm? Like, can you do the sequence? Because really, at the end of the day, if I look at how we're training medics right now and non-medics, and any medical training is so algorithmic based that, all right, did you hit these gates? Did you follow the checklist? Blah blah. But, like, that's not realistic, and we train on all these unconscious, unresponsive simulators because unless they don't move, they don't help, they don't, like, every trauma casualty I've worked on, like, I can count on one hand the number of unresponsive patients truly unresponsive patients I've ever worked on.
God, that is it. Right.
And
That's
and,
something
and,
that I haven't thought about. Wow.
and they're not, well, and that's, like, unfortunately, I've had to deal with a fair amount of death in my career, and putting people in body bags, which, like, when they move their arms weird, like, I was like, oh, are you still alive? Like, no. But, like, you don't deal with, like, if someone's unresponsive, like, deeply unresponsive secondary to trauma, like, are they alive?
Right.
Because they're usually giving feedback, they're usually giving some sort of push pull, like, there's something going on, but we don't get that in the training space. So we don't have, like, medics can't talk to patients, they don't know how to communicate to patients. Like, to be honest, when the CLSers, the combat lifesavers that go through, like, always seem to get it better, because they're not stuck in this medical algorithm. Because even, like, you look at physicians going through residency, like, I've seen it time and time again, like, in R2 and R3, like, you know how to talk to people, mate. Like, because I literally was on a hospital rotation one time, and they were doing a chest tube in an ICU. So of course the patient's draped head to toe. No one's talking to them. I
Right.
get on the drape and explain to them what's about to happen, because, like, it's a non-emergent chest tube, like, so it's drawn out. They can't see. It's like, And that is one of those problems about medical simulations is when I'm dealing with a mannequin on a tabletop, yes, I don't have to talk to it because it's rubber.
Right. Yeah.
And that's where like a lot of the training aspect, like we fail to capture. We'll talk about the humanity. Yes, we don't have the humanity captured. No.
Do you
But that's
train to that? Like, since
I
you know that, do you
yeah.
train, do
Oh,
you tell
absolutely.
people that in your
Mm,
courses?
yeah, because like something like ketamine. Ketamine is our frontline analgesic drug. Like went, I got an operation done, and I asked anesthesia, like, "Hey, can you induce me with an induction dose of ketamine because this is my frontline drug. I've never gotten it. I don't know what it feels like, so I can't relate to a patient that I give this to." So
No
they did.
way.
It was great. But like no, like I had the disassociation, like my body detached from my mind, and like had I not gone through that, like I would never know to teach people now. And also, if I ever have to give ketamine, like you can talk your patient through the high. Because
Wow.
everybody's answer is like, hey, just give them Versed and they won't remember. I'm like, well, they're still going to have the feelings. They're just not going to remember them.
Mm-hmm.
So, but, and that, like, you hear time and time again, the people who are come up light in the operating rooms or come up light during sedations, like the people who get sued for being made fun of in an OR, like people, like we fail to remember that the problem we're dealing with is connected to a very powerful tool that will like it's not just a dummy, it's not just a simulation, it's a human being that if you forget the humanity aspect of it and don't communicate. And that's where role players are great. It's like, because I actually had this experience where I was doing a training event in Fort Bragg, or Fort Liberty now,
Yeah.
where one of the role players was playing the psych patient. I said some snide comment, smart ass comment, because it's what you do in training. And the guy literally comes up off the freaking bed and grabs me by the throat. It's like, wow,
Uh-uh.
yeah, that was good. It was a good learning experience because it taught me,
Right.
yeah, yeah, it's the classic FAFO freaking acronym right there. But like, you you don't know till you know, and like you forget that so much of the nonverbals or the side comments or like having a conversation about the patient in the room when you
In
think they're
front of the
unresponsive.
patient.
Yeah,
Right.
happens all the time in the ICU where like you're like they're having like no, if it's a sensitive conversation that may affect the patient, do it outside because people remember, they hear, like even if even if they're not consciously aware, if their subconscious is hearing
Yeah.
things, then like the will to live, the will to survive is a powerful thing. And if I take, and that's like just shows how complex that the full spectrum of patient care is. And oh, by the way, in military medicine, we expect it's more like on the like the special operations side, we expect our medics to do combat things, paramedic things, nurse things, doctor things, anesthesia things, freaking medical planner, administrative things, like all in one person.
Right.
There's and that's the problem with military medicine is like we put our most inexperienced people, our line medics, our line medics are the most inexperienced medics in the entire military. We put them in the most autonomous positions and we don't teach them how to think. We teach them
Mm.
how to react. Teach them how to react, sort of. We do not teach them how to think. And
Gosh, that's major. I mean,
we
this is major. Sorry, go ahead.
well, oh yeah, good. Well, and two, like on the Army side, I don't know how Navy and Air Force is. Like, so the Army has gone to what we call soldier-centered medical homes. Like, they're basically clinics. They're traditional clinics. We're trying to replicate the high quality of care that we see on the civilian side. But the problem with that is now that the medics work in these clinics, they do vital signs and maybe admin stuff. They're not doing full patient encounters. When I was a young line medic, like working in my squadron 8 station, we run sick call, and every time we had a patient come in, like that was your patient. You would do a full head to toe workup on whatever they were worth. You'd do the physical exams. You'd staff them with the provider. You'd write the note. Because back in the day, the electronic health record, the medics could do start to finish
Crazy.
notes. I could put labs in. I could put X-rays in. I could order things, and then my
That's
provider
awesome.
would just countersign it.
Mm-hmm.
Like if we're gonna throw something, like if I want to flick a booger at, and I like the military health system, it's like the electronic health record they've gone to MHS Genesis, while it matches, it's a Cerna-based system and it's a good product for what it is, but it's a clinical-based product where like there's no super user. Like I can't get in there and write a note like to truly check a patient in. Like I may have changed it, but like it takes an admin person to check them in. It takes a nurse or a medic to write an ambulatory RN note, and it takes a provider. Like there's
Wow.
no ability. Like when we had Alta, like literally could go start to finish. So now, due to this like standard of care that we're trying to achieve, medics can't get the patient reps because you're now like like when I was value added when I was working at my squadron station. If I went to a soldier setting medical home now as a medic, I'm delaying. I'm now being an inefficiency as opposed to value added.
Wow,
And when
that's
you be
major.
and when you become inefficiency in a system, you get pushed out of the system. And that's why medics are just in the motor pool. Like so we have like I've got medics coming through tables on the Mystic. Like the only medical training they get is every 2 years when they come through table 8 training. And they haven't touched a human patient in those 2 years. A human. They have not touched a human in 2 years.
Wow.
And that's where the biggest gap in military medicine is we're giving these young kids this responsibility to be in these autonomous locations, and they're not even getting to do clinical and like true clinical encounters where they're doing a physical exam and hey, normal or abnormal. Like I don't need you to diagnose everything, but I need you to be able to explain what you're seeing that isn't normal.
Yeah.
So like
So how do you fix that? I mean, number 2 questions. How do you fix that is a big question. But would you say that then these guys and girls are getting their training just when they're in combat? I mean, they get their training if they go. So that, I mean, is that where they learn the most?
It depends. Like everything depends. But like, yeah. If you're talking about patient contact, yeah, it's going to be experiential based in whatever.
Yeah, wherever they go. Right. Yeah.
Because like it used to be, some units still do it, where like you might do sick call, initial screening at the company level, and like, but like we've evolved because we're trying to replicate. That's like DHA has a very hard job. Like I'll give them, like I won't poo-poo them ever because like they have a very hard job and the services are fighting them tooth and nail. Their job is to provide world-class healthcare with the emphasis on medical readiness for the fighting force.
Yeah.
Their primary duty is not to do. They're not supposed to do operational medicine. That's not their task. The job of the DHA, the intent. If you again, I know you've already talked to some DHA folks, but like really the intent on paper, if you look at it, was to reduce the burden on the services to manage their CONUS, their home base clinical medicine, so they could then focus on operational medicine.
Right.
But everything, like just because it's briefs well doesn't mean it executes well. Mm-hmm. So like how do we fix it is like the only way to fix it is to get patient reps. Like I need to touch people. I can give people training reps, and like that's the thing with training, and the closer I can get it to like 100% act, like I can't just say 100%, like but like true stress inoculation, like that's probably the biggest challenge is how do we stress inoculate people so they don't freeze up when they have to rapidly critically think.
Yeah.
Because that's a big one with like I hyper focus like for the March algorithm, like hey, MAR, like okay, massive hemorrhage area respiration, you got 4 minutes to solve every single problem in one of those, or they're not going to make it anyway. Can you do advanced procedures in that time? No, it's all basic stuff.
Right.
You stopgap the immediate life threats, and then you take a breath and think about, okay, what do I actually need to do next? I know, by the way, in the combat scenario, a lot of times, sometimes it's continue fighting forward.
Right.
Because this is not World War II anymore, where medics are just medics. Like you're now a warfighter,
right,
with a weapon system, and until the situation has been suppressed, like it's not go and run up and treat patients. It's like a lot of times you have to fight back.
Yeah, that's crazy. Okay, let me ask you this: when you're training, in this podcast, some conversations I've had, it's with the best people, God, ever. And when you said that, I was just like, yep, there you go. You're just like it. That talk about the stress inoculation. Is that how you say it? uses inoculation very often in my day to
They're not
day.
inoculating people.
Yeah, where's the stress inoculation? I kind of get the vibe, but what are things that you do? Because I don't see that enough. I don't see it enough. But my best people, I mean, like the elite ones that I talk to, they make their scenarios so that they're really freaking people out. Like you time it, you make a lot. Like what kind of stuff do you do to do that to help other trainers?
So for me, like I always when I'm mentoring other instructors, particularly, it's like I'm not a sequence Nazi. I
Mhm.
don't believe in blindly following algorithms. Like, and it's obviously taboo. It's like no, like I understand why algorithms exist. I do not agree with the discounting of people that are based off algorithms.
Yeah.
It's like you need an algorithm to react when you don't have time to think. And there's very few situations where you don't have legit time to think. Like for the tackle emergency casual care, like direct threat. I like that term, direct threat. I always ask my students, "Hey, what's direct threat?" And like you have something that actively can kill you very quickly. That's direct
Mhm.
threat.
Yeah.
You don't have time to think of that. If I have true massive hemorrhage, I don't have I don't have time to think about that. That's why direct pressure point, a finger on it, because like I need to stop gap so I can think. Do I need to do something next? So like that's like I basically will just. I'm not a huge like because walking that fine line of like I don't want just people to blindly react, but like, I also want them to think. So I ask why a
Yeah.
lot.
Right.
I'll ask
That's
them
good.
why. Putting up like timers, like I'll just tell them they killed their patient. Like, hey, it took you freaking 2 minutes to put a tourniquet on a wound that didn't need it, and while they're bleeding out from this other site that you missed, so they're dead. You want to try again? Because it's such a fine line. Like, because stress inoculation, if you're making people go code black in training, you're not training them, you're breaking them. Like
Right. Right. Yeah.
I need to redline them, and so putting them in uncomfortable situations, environmental considerations, cold, hot, wet, dark, because that's a value add too. It's like, hey, why are you working in this crappy place? Did you think about moving your casualty? Oh, we could do that. Yeah, man. Like, and that's another big thing I do too as an instructor is I let the scenario play. Like if they go to like, if they find something in their environment, like say I've got this laundry basket and I have a pediatric patient, I'm going to use my laundry basket to carry the pediatric patient. Like, okay, go do it.
Yeah.
I will always reward like the adaptive critical thinking because I don't
That's
want to
awesome.
train that out of them.
That's awesome.
But I will say, like, I'm not tooting my own horn here. Like, I do not see this replicated very much.
Hmm.
Um, it's hard. And like, I think probably the biggest failure that I see when it comes to trainers is we don't really do a good job truly developing our educators. It's hard. Like, a lot of people get, like, when we think about instructor positions, they're not sought after most of the time.
Yeah.
There's no incentive to go be like if I wanted to be an AIT instructor, advanced individual training instructor, like there's no additional pay, there's no incentive. Like yeah, it's allegedly a broadening assignment, but it's not one that it's like you want your educators to be fighting to go to the positions. That's why
Right.
like academia is not perfect. Don't get me wrong, but why are all tenured professors PhDs? Because they
Hmm.
want them to work hard to get there.
Yeah.
Like and we don't. And sure, we don't have the resources to do it and export it, but like it, you have to like part of being an instructor and a leader, like you are a leader in the military or like servant leadership, whatever you want to call that. Like, but
Hmm.
part of your job is to inspire people to be better. Like,
Yeah.
hey, I've only got 5 days with you guys here. Like, I'm gonna scratch the surface of what we're gonna focus on, but like your goal is to go out and be better, figure out how to do this. And to be honest, like doing the teaching cops, like the most creative people I have come across have been non-medical people because they're able to think outside the box. They haven't gotten caged in by like, hey, you need to stay in this checklist. You need to stay in with this device. You need to do this procedure this way. You need to do this procedure here. Like
Yeah.
they just creatively, like, because they're given the problem and then they problem solve through the problem.
Yeah.
That has been one of my core tenets of my instructing is like I want people to understand what the problem is. I
Mm-hmm.
will show them some tools to solve the problem, but if they understand the core fundamentals, the core physics, the core like science, the basics level science of why something is going the way it is, like now they can come up with solutions on their own.
Yeah.
And I think that's
Yeah, that's good.
the biggest challenge we have as any educator, period, is communicating or sparking the curiosity for people to dig further into the why.
Mm-hmm.
That's why I'll ask why did you do this? Like that's why I'm not a sequence Nazi. If like someone goes off slightly, okay, you handled this before you were supposed to. Like I very simple. It's like if something they did doesn't hurt the patient or doesn't have like long term potentially detrimental outcomes, like okay, cool, you
Mm-hmm.
did something out of sequence. Oh
Yeah.
well. Did you stop the bleeding? Did you open their airway? Did you handle the immediate respiratory threats? Did you get evac going? Did you like my biggest pet peeve is if someone delays evac for like if you're delaying the things to get the patient out, then
Yeah.
that's a no go in my book all day. Because
Let
if
me
we
ask you about that really quick. Do you have you have you noticed I don't even know if I'm saying have you noticed. What are your thoughts on keep holding the patient so much longer now?
so prolonged field care, I enjoy the challenge of it. Um, but like honestly, I'll give Caleb Twilliger as a guy I used to work with who created at Fort Lewis delayed evacuation casualty management course, which is
Ooh,
it's basically it's PFC, it's prolonged casualty care, like whatever you want to call it. But the reason why I like that term better,
I love that term.
delayed evacuation casualty management,
Right.
because it's already identifying it's a contingency because like evac is still the primary goal, but it's become delayed
Mm-hmm.
and it's not casualty treatment or care, it's management because you're managing the entire you have to work rest cycles, you have to work freaking logistics management, you have to work,
Yeah.
hey, do I have a target of opportunity evac platform that okay, just because it doesn't have red crosses, is it going the opposite direction or is it going the direction that I need to go in? Then you should be putting your people on there.
Right.
Because like what prolonged field care and prolonged casualty care do is since words have meanings, it gives commanders the belief that their medics, oh, you can hold this casualty for this amount of time. Like, no, if a casualty needs to be evac, they need to be evac. Hard stop. There's no sit on them for 72 hours. There's none of this. And I actually spent a lot of time digging into this in the military. Like, there is no doctrinal level patient hold criteria except for the Role 2 level of care in the Army health system is designed to hold patients for up to 72 hours who can be returned to duty. So the
Oh.
Role 2s, their design is because again, the military health system is your goal is rapid evacuation in the operational environments, rapid evacuation of those who need it, and then
Mm-hmm.
return to duty as quick as possible. Those are the two primary goals, and so that's why the Role 2s like if I have a combat stress or someone that just needs a little wound washout or needs to be sewn up a little bit, send them back to the Role 2, let them take a nap for a couple of days, then send them back to the front. If
Yeah.
people need to go back, like if there's like a surgical patient or someone that needs to go to Role 4, the system is designed to expeditiously move that person back to the Role 4 as quickly as possible, because even a Role 3 level of care is now like that's a like it's a operational level as a not strategic level. So they still may need to move, and if they're full on patients, it's not easy to move them. So like, how do we get rid of the not rid of, but like how do we move the casualties back? Like that's another thing that we you can't simulate. Like you can do it kind of like command post exercise wise, but like that's a pretty major system that also doesn't get exercised unless we're in conflict.
Right.
Um, so like it's since we're talking about simulations, like I've thought about this a lot. It's like how do we like I brought this to industry a bunch. It's like how do I get high quality, high fidelity, medical based training that forces people to do the full like to be like it's a real time role play game. Like
Mm-hmm.
I look at the Call of Duties out there, the freaking I don't want to hyper focus on video games, but like how can I get people to think in a manner that doesn't require me as an instructor to do the massive amount of work creating a scenario that like then like the
Yeah.
next 2 weeks I have to go hibernate because my brain's drained. And then
Yeah.
two, like how can I stop a scenario like, hey, you screwed up. Let's go watch the tape for a second. This is what happened, then roll them back and try again. Or maybe and then change the scenario ever so slightly through whatever interface. That way, they're not just going like it because then now you're teaching the brain how to be like neuroelasticity, like that
Yeah.
buzzword.
I
Like
like that.
how do I train the brain to be flexible? Like yes,
Have you seen anything like it? Like, have you seen anything that comes
they,
remotely? I mean, it's like
they
AR.
there are people working on it.
Mm-hmm.
And I just like you bring up the mannequin space, like how much money the military has spent on mannequins. Like I know at the Layer 3D, $100,000 a pop or something. The Trauma
Yeah.
FX, the top and bottom's 160 grand together. Like
Mm-hmm.
literally flip the booger. Like you probably could even develop an internal. It's like with there's a lot of smart kids in the military, like coders and programmers.
Oh gosh, no kidding.
Here, homie, take this Oculus and build me a way to stress out our medics.
Mm-hmm.
Because it's not an end all be. And like I get it. Like you can't like AR, like augmented reality would like a good augmented reality that I could put an overlay on a human based role player, so they move like a person as opposed to a dummy.
Yeah.
Like give them like an AR suit, whatever, like the green screen suit, like that way they can inject, put stuff over top, overlay it would probably be the closest thing to perfect.
Right. Right.
It would be hard, and it would take a lot of science to get it to be like so. Like if I was doing like, okay, if I'm grabbing, and then like to do a crike or an IB or something, but like to be fair, like I can't replicate like treating a real human,
Right.
right?
Well, I know.
Unless
I know. I love that how much we've talked about that because that I have just really been thinking about that a lot when I've gone out into the physically in the field I've just seen lately. Like I'm over the mannequin situation and I sold a lot of them. So believe me, I like selling mannequins. Like, but it just there's now it's at the point where it's like, okay, dudes, like we don't need another freaking mannequin just because you've got 130 that you got to throw away by the end of the year. Like I'd rather you get 10 kick-ass task trainers and or whatever, and or spend that money on something. You have a mannequin. It is fine. It's not dying. You got 16 of them, right? It's like, good Lord. But I want to ask you about I want to go with the video game for a second too. I've always thought about this too because one of the things that when I talk to the guys in San Antonio for MTF sim training, right, for all the MTFs, they'll talk about like during COVID. I know that you guys all worked during COVID. We couldn't set foot on the base until we got the vaccine, but but I know you were active duty, so you worked and you went in. We were doing everything via like cell phone, standing on our legs because we couldn't even do Zoom meetings with you guys, trying to get all the trainers their stuff, but like we couldn't Zoom in case Russia jumped in. So, so, but my MTF guys are like, they said that they want that same sort of like video game type training thing, and that would have been so killer during that time because people were trying to go into Sims alone, and then VR wasn't enough, or whatever it was. It's like it would be cool if technology came out with something that the medic can do on their own, to practice or
yeah.
something, and
And
yeah,
there are places like because you look at a lot there's AR surgery trainers, there's a lot of good stuff out there. The problem is like they're very focused on provider level. Like the pre-hospital space is really hard because it's hard to replicate.
yeah,
But even if I was able to give someone a 75% solution where okay maybe the hand movement wasn't perfect or whatever, like if I can still get them think, like, because I really need them to think. Like, I need them to assess. I need them to think critically. I need them to rack and stack priorities of work. Because, like, the thing is, like, with partial task, I can teach people what they need to do with their hands.
yeah,
Like, I'm a
right.
partial task trainer. I can teach you the hand, like the body mechanics of criking someone. I can teach you the mechanics of putting an IV, and I can teach you the mechanics of running an ultrasound. But where we are currently lacking the most is tying all of it together in a manner that's easy to replicate, easy to reset, easy to maintain, that doesn't require a ton of bandwidth from the person who's supposed to be mentoring this person.
Yeah.
Like, because like if I can watch a sim, like watch the screen and see what they're doing, like actually focus, take notes, like not having to troubleshoot a freaking mannequin, not having to troubleshoot a partial task trainer, not having to be like whatever, like because then too like we just got this whole sim video blah blah. But the problem with like a lot of this technology, a lot of the this is what I wanted to hit on. A lot of this technology, the maintenance burden's massive, and we don't have people trained to do it.
Right.
Like we don't have people trained to do it. We're not resourced to maintain our partial task trainers, our mannequins like we're supposed to.
Yeah.
And then
I don't think Army can buy. I don't think you guys buy warranties, do you? Like
they're like for like a year, but guess what? Everything breaks after the warranty.
I know.
I know. But then too, the operation burden, like operating this stuff, if it requires more work for me to operate it than to like I'm not going to use it.
Yeah.
To be perfectly honest, like you look at all the technology, the medical technology that sits on a shelf, like our MC4 computer systems, like it was more of a just going back to the medic and the electronic health record. Like if it's an inefficient, if it's in an inefficiency, you have to look at, is this inefficiency worth the value? Like, but very rarely is the value up here. It's always usually either parallel or below it.
Yeah.
So like if it's value negative and it's inefficient, no one will use it. If it's value neutral, you'll probably see that.
Yeah. God, this is all so good. I mean, thank you. I hear you made me think about a lot of stuff. I know of something that you need to do to start your own business. I've written a business plan for you over here of something that you need to.
How about I just give you all the ideas? You can take all the credit for it, and I'll continue doing nothing.
I don't want the credit. I want you to do all of it. But I'll just because I'm now your little sister, so I'll just like I'll type it up for you and send it to you because you'd be good at it. God, I could talk to you forever. This is amazing. Let me ask you one more.
We can do it again.
I know. Well, I want to, if you will, please.
Yeah, I'll be your habitual guest.
Okay, good. I like you. Good. That'd be good. I would love that. I love this stuff that you're saying, and it's stuff that I hear from really the people I respect the most. And so that's like, it's even, I don't know, it just continues. I always feel like there's like so much more we can do, and then I get all these ideas, but it's so nice to have. I think that probably it's awesome that being an instructor, it is a labor of love. And but it is taxing on the teacher. It's taxing, and it's not a lot of glory, I mean, it's like that. What happens is, but then someone comes up to you somewhere at some time and says, man, the stuff you taught me, I saved my battle buddy. And you're like,
yep.
Yeah, then that's the best paycheck in the world, so it's like, yeah, it's, I mean, I'm sure it's like parenting, shit. But I want to ask one more question before we go this time. But of course, as my habitual guest, it's certainly not going to be the last time. How do you think, especially with you just retiring, all of the stuff that you named for like the instructor, but also the medic, the medic, not an instructor, but the medic out in the field, you've been to combat. Do you feel like that all of the shit that you have to manage and everything you have to manage and stuff like that, and then going to combat, being a medic, seeing what you saw, you said body bags, things like that, too much death, those types of things. Do you think that the PTSD stuff, does that weigh more on, do you think that mental health, does it weigh more on a medic because you're the caregiver to the soldier?
Yeah, so we can talk about this next time, because this is like mental health is one of my big passion projects. But like, that's
awesome.
Another thing
I would love to do a whole thing on it. Please.
I got content for days.
Okay, good. Yeah, I would love to. But
think about a military medic. So here's the military medic's rub. I'm embedded with this platoon of 40 dudes. Like, I may have some differences. I may have some like people I like, people I don't like, blah blah blah. Like, at the end of the day, is one of those 40 people gets screwed up, or there's multiples, like now I'm racking and stacking, like the juggling of like okay, maybe my best friend needs all of the
Yeah.
work, but I have 6 other people that I need to focus on, or there's enemy combatants tied in, and now with Geneva Convention, like I have to treat them as well. We do it. I don't think we do a good job at all with even preparing people for this is, and I've had unfortunately a lot of experiential based learning on this, and I still continue to learn. I can talk for days about all the things I screwed up. To be honest, I've screwed up more things than I've done right. And that's put me in a position where I can be a good trainer and be like, hey guys, like I've made all the mistakes. That's where I also have a very hard time with go, no go criteria. It's like, no, it's, to be fair, if I'm no-going someone, that's on me, man. Like if I have to no-go, like I didn't train you well.
Yeah.
So like that's for every military educator out there. If you no-go any of your students, you failed them. Not them failing you. You failed them. Like obviously there are some people who can't get trained, but then okay, what are their strengths, and where can I reassign them to leverage those strengths? And I've dealt with that all the time. Like it's talent management. And one of the things special operations does better, not great, better than the conventional forces, we manage our talent. If someone's not cutting the mustard in this position, let's try them over here.
I love that.
Yeah, it's a puzzle. It's like I can't jam a piece and make it work. If the piece fits, the piece fits. If it doesn't, like I need to find the other piece.
Yeah, I love that. I love that.
And that's like going on the mental health aspect. Like I brought this up in the chat the other day. I was like, why don't we do more, like the cognitive based apps, like Lumosity? I know the science and other, but like something that scientifically based that you can get aggregate data and like, okay, not only am I going to base my talent management off of like these psych tests, but now I have all this cognitive data that shows, hey, this person will handle this situation better than this person. So why don't we flip flop them and put them over here? Or like, especially instructors, like, do I have, because for an instructor, like I say, neurodivergence, I don't say it's a bad thing. It's a superpower. Like my ADD is off the charts, but what it does allow me to do is rapidly bounce back and forth from things. I can't multitask because that's not a thing, but I'm able to bounce very quickly. And like, when you're in the training space, like especially like not the narrow focus training space of like a specific task, like I have to cover the full spectrum. Like you have to bounce around, and it's an art. And honestly, I don't think you can teach it. Like I think
I know.
Like there's so much of the stuff we're talking about is literally you have it or you don't.
Yeah.
And my thing is if I'm going to go to force generation, it's like, how can I get the data to figure out who has it, or they go code black on a scene.
Yeah.
Because this applies not just military medicine, it's fire, law enforcement, medical, healthcare, anywhere that you work with people or serve people in a stressful environment.
Yeah. God, I do want to talk about that more. But that's awesome. And I'd never heard code black before. So that today was the first time I heard that. I like that saying. I mean, it's
a law enforcement thing.
Okay, I didn't know, and I like that a lot. I understand it big time. All right. I love what we talked about today. Thank you. I mean, I think there's so much that y'all do as instructors, planning simulation scenarios, picking your equipment, dealing, gosh, all of the different aspects of things that you need to juggle. And I thank you for it because I do know that I know it's a hard job, but it takes someone who's madly in love with it, and we're like usually the crazy ones, like. But it takes someone who's just like freaking madly in love with it. I mean, but everybody who's listening to this right now, those are your people. That's who we are. So, thank you for that. I do want to get you to come back, but we'll end it at this. Thank you, Sam Patrick, and everybody. He is out in the Seattle, Washington area. So Sam trains it as an instructor and consults. So if anybody's in that space, I know that people are always looking for trainers out there too. Then reach out to me and I can connect you with Sam. So Sam, thank you so much for being on today. I want to follow up and do some more, and but I know that we had some really good just today. I'm walking away with a lot of stuff, so I really appreciate your time, and
My pleasure.
congratulations again on your retirement.
Yay.
Yay! In your party, like in a couple weeks.
Yeah, we're gonna do a little shindig for the boys.
Awesome. That's awesome. All right. Well, thank you for your service. I'm gonna and thank you everybody up for listening to Splints and Whiskey today. And we will get back at you soon.